Hi, I'm Eloise. Today I'm pitching a proposal for staggering staff work hours here in the musculoskeletal outpatient department at Oxfordshire Community Hospital. The reason for this proposal is because currently there are no appointments outside the core 9 to 5 work times. This means those who have childcare, work commitments and are experiencing particular health conditions sometimes miss their appointments, and therefore there are high rates of DNA absences. This is meaning unattendance and underutilisation of appointments, which is an efficient use of our time and resources, and patients are missing out on their vital care. Tan et al. Discuss in a UK MSK physiotherapist service, 23.76% of new patients do not attend their first appointment, and 23.74% of current patients failed to attend their follow-up appointments. And the National Institute of Reference Costs reports that missing a single appointment costs the NHS £187 per patient. On average, in a UK MSK physiotherapist setting, 96 patients miss their appointment, meaning a loss of £18,000 per week to the NHS. These facts and figures bring attention to the high proportion of missed appointments and the financial burden this is placing on the NHS. Staggering staff working hours means our service can offer more out-of-hours appointments outside the usual 9 to 5 work times. If some staff started later and ended later, for example from 10 till 6, or started earlier and finished earlier from 8 till 4, it would enable appointments at times that some patients may be able to make more easily, therefore having a positive effect on patient attendance by reducing missed appointments and cancellations. Relating to diversity, patients with childcare commitments during the day with school run or pick-up can attend an appointment early morning or in the evening, and the elderly will be able to attend appointments maybe mid-morning or mid-afternoon, avoiding catching the bus in rush hour with the congestion. And patients with pre-existing long-term health conditions, for example spinal cord injury and COPD, maybe can't wait long times in the cold for the bus, so can travel at off-peak rush hour times. Staggering work time supports the NHS 10-year plan by improving patient access to services through reducing wait times and enabling more efficient use of staff and resources. My aim is to increase patients-facing hours and the number of patients seen each day by staggering staff working hours to better align with patient availability. My SMART goals are to, number 1, increase the number of out-of-hours appointments available to occupational therapy and physiotherapy patients by 20% within the next 6 months. And number 2, to increase attendance rates of OT and PT patients by 20% in the next 6 months. I chose to structure my proposal based on Rogers' 2006 RAID change management model due to the bottom-up approach engaging stakeholders and supporting sustainable changes. Stakeholder engagement is paramount for this proposal's success. For this proposal to be successful, I must endeavour to best understand existing problems in the outpatient MSK department through gathering anonymous feedback from stakeholders, through anonymous staff and patient feedback surveys, then ensure the change project fits our organisation's priorities. When implementing change, I will arrange the main stages of the project with the Gantt chart change management model to review its progress and finally document on the change process and evaluate the impact of implemented change. Although this RAID model fits well, other models could suit this proposal, like Kurt Lewin's change model of unfreeze change and refreeze. This would be efficient in preparing stakeholders for change, introducing change and making it the new normal. However, Lewin's model lacks a bottom-up approach working with stakeholders at the forefront. The Fishbone Quality Improvements Planning Tool presents a very visual breakdown of all the stakeholders and why proposed change is needed through the cause and effect presentation. For example, there are currently no staggering of work hours, which is resulting in overcrowding waiting rooms and limited gym equipment. These factors are placing a great administrative burden with the backlog, OT and PT staff are overworking and team morale is low, which is knocking onto inadequate quality of care delivery to patients and further patient dissatisfaction. This is then resulting in decreased patient-facing hours to coincide with patient availability. A SWOT analysis is another alternative which can work with mapping the strengths, weaknesses and threats and opportunities for growth in our service, which is good in the sense of bringing to light the main areas of concern. However, it's too general and descriptive and does not provide a deep analysis. It just shows what is currently going on in the service. Here I present the key stakeholders essential for my proposal and practice. These are OTs, PTs, rehabilitation assistants, hospital administrators, cleaners, IT staff, patients and families of staff and patients. The most important way to engage stakeholders is through face-to-face conversations which promotes understanding. Team meetings and ward huddles, specifically with rehab TAs, PTs, OTs, hospital staff, regarding on-the-day workings, provides active communication and cohesion throughout the team. Anonymous patient surveys with the PREM and staff Gallup Q12 feedback forms are essential in gaining insights and are time efficient and provide observation of trends. Health education posters with attractive infographics enables patients to retain and recall vital health information while being financially viable means of enhancing understanding of the proposal and promoting awareness, as Noor et al. Highlight. To note, the wider MDT team of nurses and doctors will be necessary for emergency referrals. As Hogan 2024 highlights, there are barriers and facilitators to rolling out a proposal in practice to an existing team. So the barriers of my proposal could potentially impact employee work and personal routines, causing a resistance to change due to childcare commitments, for example. The staggering of shifts may imbalance the work-life cohesion of staff. However, there will be ample staff training and clear communication to all stakeholders, which should facilitate phasing out anxieties. With staggering of shifts, there may be a barrier of poor team collaboration and morale, with potentially brief handovers and poor cohesion between team members working different shift patterns. However, facilitating collaboration tools like shared group chats and calendars, this can give effective communication for shift routines. The workings of staggering shifts may increase management and complexity and administrative management. A key facilitator will be phased implementation following the PDSA cycle, having a month trial period prior to the full rollout, so there will be a chance to observe and experience my proposal in practice. Here I present the Gantt chart change management tool incorporating the previously outlined RAID change management model. This is a way of visualising the process of implementation in practice. The 24-week proposal time intervals on the horizontal axis and the task stages on the vertical axis. I will review existing problems from stakeholders with face-to-face conversations and team meetings as previously discussed for the first 2 weeks. Then I'll agree with stakeholders on proposed change for the next 2 weeks, reviewing and agreeing with stakeholders for the first month. Then I'll begin implementation phase from week 5 to 9 following the PDSA cycle with 3 iterative cycles, small-scale testing, follow-up test and wider-scale test. After this, I will fully roll out the proposal for the following 14 weeks. Finally, I will evaluate the change process from observations, feedback surveys from staff and patients, statistics collated to review if staggering the staff start times has improved the amount of patients seen in service delivery for the final 2 weeks. This will mark the 6 months completion of proposal in practice. The change I want to test to see is if we have an increase in patient attendance by 20% over the next 6 months, and I predict and expect to see a rise in the patients we will see and have a positive feedback from patients and staff due to a more streamlined work schedule, this aligning with my SMART goals. I will evaluate the proposal effectiveness in practice with the PDSA cycle timeline as discussed in 2023 with the NHS in 3 iterative cycles as outlined with the PDSA testing ramp from North West London 2025. First cycle is a small-scale test, second cycle is a follow-up test, and third cycle of wider-scale test phases with phased implementation from weeks 5 to 8. The evaluation of goals based on the PDSA cycle with a final evaluation with the number of out-of-hours appointments available and the number of patients attended as per the audit documentation. See next slide. With the PDSA cycle, with the cycle 1, 2 and 3 happens before the full implementation rollout as we are focusing on the implementation in my proposal. With the small scale follow-up and bigger cycle tests, I plan with 2 therapists, 4 therapists and 6 therapists before rolling out to the whole department. With the do, I ensure collection of data at each stage, including out-of-hours patient appointments, patient attendance rates, staff and patient feedback with the PREM Gallup 12 surveys, studying, reviewing and analysing patient and staff feedback and acting upon these by refining this in cycle 2 and 3. The PDSA is split between weeks 7 and 8, with the plan and do in week 7 and the study and act in week 8. An alternative quality improvement implementation tool discussed by the NHS England 2017 in quality service and redesign tools is the 7 steps outlining the aim with choosing measures, defining measures, collecting data, analyse and present, review measures and repeat the steps. This complements my model of improvement with the PDSA cycle. I like the PDSA. It's a well-structured approach with a clear method for developing practical measures and is reliable for when reviewing patient survey statistics. However, it's very time-consuming, collecting the data, which is a challenge with this small-scale MSK outpatient community department. Implementation and documentation is crucial for recording the proposal practically to observe the daily workings. Above you will see the daily schedule for the staggering of OT and PT work hours inspired by Marsden 2025. As per my PDSA cycle phased implementation, developing with 2 staff per small scale test, follow-up and wider scale test. Staff will be paired per shift to aid communication, understanding and collaborative practice. 2 staff working an 8 till 4, 10 till 6, 12 till 8 shift. Below you'll find the audit form presenting a means of collecting the statistics for attendance of out-of-hours appointments available, as this is my goal. Evaluation of the PDSA and audit. The audit form and attendance, patient feedback PREM, staff feedback, Gallup Q12. The statistics gathered from the PDSA audit will present if there's been an increase in appointments available in attendance. With the evaluation of goals, the final evaluation incorporates number of out-of-hours appointments available and the number of patients attended. It is crucial to review how my proposal can positively impact patient care, which is the forefront of my proposal, with goals to increase out-of-hours appointments and attendance rates. Increasing appointment availability improves accessibility of care for patients as they can attend out of their work childcare commitments. Efficient use of time and resources means that there will be available treatment rooms. Patients won't need to wait or have to share a treatment room with other patients. Staggering staff working hours will free up waiting room crowding, phone call queuing, enabling a steady patient flow. More fast, efficient and regular follow-up appointments and discharging for patients. However, there is a negative impact to consider with the inefficiency in care delivery. So there's a poor continuum potentially in care delivery, patients feeling maybe they are repeating their story, getting inconsistent advice, which can be frustrating when having a different practitioner per appointment. Often MSK staff bounce ideas off each other. Staggering staff work hours means they're less likely to have staff available, so staff confidence can potentially drop and care quality can therefore decrease. Patients waiting longer for results, answers, follow-up appointments as senior staff able to facilitate and impose decisions maybe aren't in or finished for the day. Consistent staff not being around at the same time reduces chance for in-depth handover, missed information and miscommunication, therefore delays can happen. This increases pressure overload with less teamwork and decision making. Mapping my proposal with sustainable quality improvements and the triple bottom line discussed by Mortimer et al. 2018, it is clear the benefits experienced for patients and staff through the environmental, social and economic impacts. The environmental elements will work towards meeting the NHS 10-year plan to be carbon neutral by 2040. Everyone has a role to play in sustainable healthcare delivery, and this can be improved by reducing carbon footprint. With my staggered shift schedule proposal, staff can shift pair and carpool to reduce fuel emissions at rush hour time before work. And for patient aims to increase appointment slots and attendances, means patients can tie their medical appointment with other life demands, i.e. work location, dropping children off at a swimming club, for example. This results in fewer wasted single journeys, which are a great strain on the environment. Transport is the largest emitting sector of greenhouse gas emissions, producing 26% of the UK's total emissions in 2021, as per the Department for Transport and Environmental Government Statistics 2023. Economically, do not attend appointments cost the NHS a lot, and with my proposal, £187 per patient can be saved as more appointments will be utilised with a larger span of working hours throughout the day, and therefore more patients will be seen daily. For collaborative working, there must be a primary focus on shared goals. I mapped my proposal with the Collaboration Compass model, a tool to support collaboration in practice by highlighting the importance of the individual, social and organisational influences. This is crucial with my proposal in developing, overcoming barriers, maintaining shared goals, limiting time restrictions imposed with shift restraints and disrupting with poor teamwork. To eliminate barriers of poor teamwork when rolling out this proposal, stakeholders must be well informed, assign and exercise responsibilities with the use of collaboration tools, for example, shared group chats and shared calendar. Collaborative practice working smoothly from the bottom up relies heavily on an inspirational leader. I considered democratic leadership style with its focus around engagement and communication, but decided upon transformational due to the focus around inspiring and supporting followers, as Norton Nicola state, directly linking to my proposal mapped with the RAID model, getting stakeholders on board. In practice, I will use the transformational leadership style specifically during the first 4 weeks with the decision-making process, when reviewing problems with stakeholders and agreeing on proposed changes to boost the morale of fellow PTs, OTs and therapy rehab staff. I'm aware the focus on vision and inspiration can overshadow need for clear, concrete goals, which juxtaposes my proposal following the 3 iterative PDSA stages. My inherent leadership skills directly linked to that of transformational style with my strong emotional intelligence and inspirational communication, which will inspire and invigorate stakeholders, in turn improving delivery of patient care. My personal and professional reflections are crucial to consider prior to rolling out my planned proposal. For effective self-management, my strengths of self-awareness, self-control and resilience are crucial, also to effectively deliver the change in practice. Embodied within the NHS healthcare leadership model, for effective leadership in practice, we must lead with care, share the vision, and engage the team. Only can we be engaging and inspirational when we are self-aware of our own strengths and limitations. Active and ongoing self-reflection is key in overcoming lack of self-esteem and poor initiative at times in the teamwork, as we increase self-awareness and ways to improve. We can't change the problem, we can change the approach through leading ourselves and leading the team, as Stephen Covey stated. The Gibbs reflective cycle enabled me to have reflective practice, digesting challenges of poor active communication as a team and ways I will manage in the future. Through Gibbs' reflective cycle, as we squash the circle of concern and increase the circle of influence, as Stephen Covey famously stated, frames the art of shifting our attention to what we can control opposed to what we can't. On reflection, I chose to focus on the strengths of efficiency and task completion in previous group work and abilities to handle difficult conversations and coaching when there was poor communication and task delegation, causing a poor sharing of the vision as per the NHS leadership model. In the future, I will be assertive from the outset, ensuring ground rules are set early on and everyone is on board to prevent individuals dominating their mindsets and outlooks towards others. Before problems manifest in oneself, I will raise concerns earlier, taking ownership and accountability. My personal goal set is within the first 2 weeks of group work, I will ensure that ground rules are set and acknowledged by all to ensure their fair distribution and contribution of tasks.